Good evening. This is Saurabh Chatterjee from the Microlabs, welcoming you all in the REGAN PG Session 7. Today we have two prominent and very eminent nephrologists who request no introductions, but with my small effort, I would like to introduce the course director, Dr. Pratik Das, who is present among us. Dr. Pratik Das is practicing nephrology in Kolkata since 2005. He runs a large volume of renal transplant center in Kolkata and has performed more than 2,500 renal transplantations, in which includes deceased donor, live donor, swap, and ABI transplantation. He works as a senior consultant nephrologist and teacher for DNB nephrology, program dialysis technicians, and his special area of interest is ABO, kidney transplantation. He has multiple papers in national and international journals and was awarded Bansal Award for Young Nephrologist in 2010, FASN in 2017, and FISN in 2019. He was the organizing secretary of ISOT, Indian Society of Organ Transplantation, in 2023, Kolkata. So without much ado, I just would like to welcome Dr. Pratik Das to start the session for all of us and welcome you all. Thank you very much, sir. Over to you.
Thank you, Mr. Saurabh, for this nice introduction. So basically, this is welcome you all for this is the 7th class of REGAN Renal classroom. And as usual, in our class, there are 3 parts. The part 1 will be the case presentation by one of the students, and there will be examination style discussion for about 45 minutes to 1 hour time. And in the second part, there will be some OSCE sessions, and that will be covered today by Dr. Aniruddha Datta, who is working as a consultant nephrologist in Kolkata along with me. And for the initial part of examination, we are privileged to have Professor Narayan Prasad as our examiner in this group. He needs also no introduction. Basically, everybody knows him. He is presently professor and head of the department of Sanjay Gandhi Postgraduate Institute of Medical Sciences, and he was a past secretary of Indian Society of Nephrology for a long time, with a very this is a glorious time of the Indian Society of the Nephrology. He was also president of this Indian Society of Organ Transplantation, and so on. He's an internationally famous person and very good teacher and very popular amongst the juniors and the seniors. So welcome, Dr. Narayan Prasad is a good friend of mine, and I'm very happy that you are in this class. And this class will be presented by Dr. Tanmay, and he's a 3rd year PGT, exam going PGT, who has recently cleared the DNB theory exam, and he will be appearing in the practical examination. He will be presenting a case. So without wasting much time, Tanmay, you can take the permission of a teacher and start the case presentation.
Okay. Tanmay, you can start. Yeah?
Good evening, teachers. Okay, so thank you, sir. So I'll be starting my case now. My patient is Miss 18-year-old Hindu female. She's housewife, resident of Madhavpur, East Midnapur. Her date of admission is 3rd of February 2025. And I have examined the patient on 4th of March 2025. History was given by the patient herself. So the patient presented to our hospital with chief complaints of not passing urine for last 2 days and difficulty breathing for last 2 days. History of present illness. The patient underwent lower uterine cesarean section on 31st of January in an outside hospital and was apparently well till the next morning, when her urine started decreasing in amount, and by the evening there was no urine output. She also developed difficulty in breathing after her urine stopped, which was acute in onset and was gradually progressing, for which she required oxygen support. It was aggravating in supine position and was relatively better in sitting position. After investigation, she was told to have raised blood pressures and kidney dysfunction, and that she will require dialysis. She remembers her creatinine to be around 6 mg per deciliter. She received one sessions of hemodialysis through right interjugular vein temporary hemodialysis catheter on 2nd of February and was shifted to our hospital for further management. She continued to be anuric, so hemodialysis was continued. After few investigation, She was also started on another dialysis-like procedure with multiple infusion of straw yellow colored fluid. She received 2 units of blood transfusion also in view of persistently falling hemoglobin levels. Her kidney biopsy was done 8 days after admission on 11th of February, and she was continued on the ongoing treatment. She also developed headache followed by transient loss of consciousness 2 days after the admission. And she said she had multiple such episodes without any memory of the events for the next few days, for which opinion of the neurologist was sought and she was started on medications. Her blood pressure remained high and she required 4 drugs to control it. After around 3 weeks of treatment, her urine output did not improve significantly and it was barely 200-250 ml per day. So another kidney biopsy was done. After the biopsy report, she was told that the recovery of her kidney function is unlikely and she will have to be continued on dialysis. Another dialysis-like procedure which was going on, it was stopped at that point of time, and a left forearm AV fistula was created on 2nd of March. Her antenatal period was uneventful. She went for regular antenatal checkups and received 2 doses of tetanus toxoid. Her blood pressure readings during antenatal visits were within normal limits. She denies any history of dysuria, frothy urine, blood in urine, decrease in urine output, swelling of legs or body, visual disturbances, headache, chest pain, breathing difficulty during her pregnancy. She completed her gestation and gave birth to a male child at term with a birth weight of 2.5 kgs by lower uterine cesarean section. Indication of cesarean section being fetal distress. There was no history of excessive bleeding or fever after the delivery. She did not give any history of joint or muscle pain, skin rashes, oral ulcer, photosensitivity, excessive hair fall, dry eyes or mouth, yellowish discoloration of eyes or skin, cough, hemoptysis, diarrhea, any history of weight loss, any weakness of limbs or loss of sensation. And there was no history of hematuria, graveluria, nocturia, or passage of any stones or recurrent UTI in past. She did not give any history of intake of indigenous drug. In past history, there was no similar history in the past. Not a known case of hypertension, and there was no history of diabetes, obstructive airway disease, or tuberculosis in the past. In family history, she is born of non-consanguineous marriage. She has one younger sister who is 14 years old. None in the family has similar or any other significant history. Menstrual history. She achieved menarche at 13 years of age, and she had regular menstrual cycles before the pregnancy. Personal history. Her sleep is disturbed at present. Appetite is decreased. Bowel habits are normal. Bladder, she is passing around 200-250 ml of urine per day at the time of examination. She has completed her vaccination as per schedule. COVID vaccination 2 doses has been taken, and she denies any history of addiction. Sir, I'm done with the history part, sir.
Can you make a brief summary of your history?
Yes, sir.
Yeah.
So, 19-year-old Primi Gravida, after an uneventful pregnancy, underwent LUCS on 31st of January in outside hospital. This was followed by decrease in urine output, leading to anuria over the next 1 to 2 days, along with difficulty in breathing. She was found to have raised blood pressure and renal dysfunction, so she was given 1 cycle of hemodialysis and was referred to our hospital. After investigation, she was continued on hemodialysis and was likely started on plasmapheresis. She likely had multiple episodes of seizures for which opinion of neurologist was sought and was started on antiepileptics. Her kidney was biopsied after stabilizing her 8 days later. Meanwhile, she was continued on hemodialysis and plasmapheresis. Her BP remained high, so she required 4 tablets to normalize it. After 3 weeks of treatment, she underwent another kidney biopsy as her urine output did not increase satisfactorily. And after the biopsy report, plasmapheresis was stopped and left forearm AV fistula was created. She is now passing around 200 ml of urine per day and is being continued on hemodialysis.
What is your provisional diagnosis, and if you have any differential diagnosis?
So my provisional diagnosis, I would like to keep it as pregnancy-related acute kidney injury. It's likely due to thrombotic microangiopathy along with hypertensive emergency. The possible diagnosis, differential diagnosis, I would like to keep first as atypical HUS, hemolytic uremic syndrome. Second will be thrombotic thrombocytopenic purpura. Third, I will keep it as antiphospholipid syndrome. And fourth, I would like to keep it as lupus nephritis.
you are telling this is a pregnancy-associated acute kidney injury, and your first differential diagnosis is basically you are telling thrombotic microangiopathy, atypical HUS. Huh?
Yes, sir.
So, what are the findings in history and your so that you are keeping this this provisional diagnosis? What are the findings suggesting that this is a thrombotic microangiopathy?
So because the onset of the disease was just after the pregnancy, and there was it was followed by cesarean section. Pregnancy itself is a trauma, and after the surgery also it could have been a second hit, and there was sudden drop in the urine output. That was the clue to the diagnosis probability is pregnancy related just after the. So the timeline of the onset of AKI along with the presentation, and since she received dialysis along with likely plasmapheresis, so it is suggestive that she must be having some thrombotic manifestation. And so moreover, she also required the transfusion of red blood cells that suggests anemia. So, anemia, renal dysfunction just after pregnancy.
So here you don't consider the patient who have the simple stage 3 AKI or a simple acute tubular necrosis. So you don't have differential diagnosis. Just suppose you forget about your kidney biopsy findings. You know? So without kidney biopsy findings, do you think there is any other differential diagnosis other than that? Why it is not a simple ATN? Defend yourself.
So ATN should have a precipitating factor. Usually, if the patient is landing if there is a hemorrhage immediately after the pregnancy leading to loss of excessive blood, that could have precipitated ATN. But she did not give any such history. Any history of fever is also not there. That could have caused some infection-related AKI.
The history of blood loss is during the peripartum period. Sometimes a patient may know, may not know. So, what is the normal amount of blood loss during LSCS?
So, around 1 liter, 500 ml to 1 liter, 500 to.
So, usually when there is already one.
It's around 500 ml of blood loss is there, sir.
During normal delivery, usually it is thought to be 500 ml. It may be during LSCS, usually relatively more blood loss than normal delivery.
Yes.
So it might be the 1 liter. You are right. 500 ml to 1 liter can be there. But making a diagnosis of at presentation, making a diagnosis of only HUS, usually you give the sentence that the patient is unlikely to recover. And so anything that is against this severe ATN. Why it is not a severe ATN? So blood loss is very comparative. So how the obstetricians measure blood loss during delivery period? Blood loss, how they say that no, this is the 500 ml, this is the normal blood loss, no, this is excessive blood loss. Then they give the blood transfusion also. So blood transfusion can be given because of the blood loss. It can be given because of the hemolysis that you are thinking of. So, sir, is there any evidence, clinical evidence that there was hemolysis? What are the triad of HUS?
So there will be hemolysis, thrombocytopenia, and uremia, renal dysfunction. So one uncontrolled BP requiring 4 drugs and along with a CNS manifestation, this these features they go against ATN.
So based on your history, we are at the level of the history. So based on your history, is there any evidence of hemolysis?
anemia could be there, but it should be hemolytic anemia. Right? So is there any evidence of hemolysis in your history suggestive of this hemolysis?
No.
What are the clinical findings you will try to retrieve from the patient for the evidences of hemolysis?
So, color of urine, if there is dark colored urine, color of the urine can be dark, sir. The patient can have symptoms of anemia, and so the patient can have jaundice because of intravascular hemolysis.
So you would have like directly sometimes this excessive of the hemolysis can have the jaundice also. You know? So was there any evidence of except blood transfusion can be simply because of the blood loss during the delivery or during the LSCS. That is not uncommon to have. So blood loss is not explaining your hemolytic anemia part. Then you have the only single diagnosis that tried of, you have to, at least with history, you should say that this is a hemolytic anemia, patient has jaundice, patient do not have it, but one soft point is that the patient has blood transfusion. Uremia is there, that the patient is anuric, so that I agree with you. And then low platelet count.
Yes, sir.
So was there any history suggestive of low platelet, or there was any information on that?
No, sir, there was no history before suggestive of low platelet counts.
So here, based on your history, at least you must have one differential diagnosis of the severe ATN. What is more common, HUS or ATN?
So ATN,
When you will take overall the view of AKI, pregnancy associated AKI. So what is more common?
Sir, 18 is more common, sir.
So usually ATN is more common. You must have, suppose after investigations, after doing biopsy, anything, it turned out to be. But at the level of the history, we must have the one differential diagnosis that patient might have the severe ATN. But several things happens during this LSCS. It is possible there is severe blood loss. It is possible that there might be some hypotension that go undetected, or sometimes even the physicians or the obstetricians or anesthetists do not reveal to the patient has developed hypotension. So risk factors during any surgical procedure is always there, may have the ATN. So one differential diagnosis, in my opinion, should be there. At least one differential diagnosis which is giving the, that is good news for the patient also. And you do not have the very strong evidences right now at presentation. And no, this is there is evidence of hemolysis. There is evidence of platelet count is not there. Then only oliguria, anuria, you can say that this patient has. So what are the different causes of anuria?
Sir, anuric.
Yeah.
Sir, anuric AKI could be because of pre-renal, it could be renal, it could be post-renal. So in pre-renal, if there is a severe dehydration, severe blood loss, in HRS AKI, there can be anuria. In post-renal, if there is a outlet obstruction, then there can be complete anuria. In renal causes, if the causes of rapidly onset renal failure, they can present with anuria, sir. And vascular causes, if there is vascular compromise, renal arterial thrombosis or stenosis, that can lead to
usually
anuria.
pre-renal causes do not have that much anuria. Pre-renal causes might have this reduced urine output, oliguric-like presentation. Total anuria is uncommon. So, but the intrinsic causes of the AKI would be there. So that can have sometimes very severe ATN. Usually most of the times ATN is also relatively non-oliguric condition. Usually urine output is, some urine output are there. So when you say that is anuria or less than 100 ml of the urine in 24 hours, then you must think of some broader spectrum why this happened. So questions comes here, you do not give the differential diagnosis of ATN, that should be always there, should be considered in any pregnancy associated ATN. So that is the one differential diagnosis I would like to have. You have also told us that you are thinking of anti-phospholipid antibody syndrome.
Yes.
That's one differential diagnosis.
Yes.
So tell me the points in favor of anti-phospholipid antibody syndrome.
So the points in favor would be acute onset and uncontrolled, very severe uncontrolled blood pressure. She was requiring 4 drugs. And sir, since with a history of plasmapheresis and uncontrolled blood pressure at an acute onset, so that's why I have kept anti-phospholipid syndrome as. Although she did not have any history of history of arterial or venous thrombosis or any pregnancy-related event in the past, but in sometimes in catastrophic APLA, 50% of the patient can. In catastrophic APLA can be present. I mean, the initial presentation in 50% of the patients. So that's why, sir, I've just kept it.
Really, what are the different criteria for making the diagnosis of anti-phospholipid antibody syndrome? Diagnostic criteria usually go by the criteria.
Sir, with the history of arterial or venous thrombosis or recurrent pregnancy loss, if the patient has, these are the clinical points, and in lab, the presence of we usually see 3 antibodies: lupus anticoagulant, anti-cardiolipin antibodies, and anti-beta to GPI. Sir, and we recheck them after 12 weeks. So if they're persistently positive even after 12 weeks, then we make a diagnosis of anti-phospholipid syndrome, sir.
So there was no any history of arterial or venous thrombosis in the past?
No, sir.
No evidence suggestive right now also. So only positive findings, any positive findings that suggest this patient has anti-phospholipid antibody syndrome?
So nothing in the past, sir.
Nothing in the past. Or
Yes.
in present, the presentation right now?
So presentation because of renal involvement, thrombocytopenia, since she was being started on plasmapheresis. So history of plasmapheresis, uncontrolled blood pressure, renal involvement, and CNS involvement. So multi-organ involvement and in a female patient presenting after the pregnancy.
So is there any essential criteria that it should be there, that because you have other points to explain for your accelerated hypertension? So accelerated hypertension is suggestive of anti-phospholipid antibody syndrome?
Sir, it can be present in catastrophic APLA, which will have a thrombotic microangiopathy-like picture.
Okay. So do you think this was a primary anti-phospholipid syndrome, or this is a secondary to some other disease? You considered lupus also?
Yes, sir. So this is likely primary because the presentation was very grave presentation, catastrophic presentation. So
you
likely
have a differential diagnosis of lupus nephritis also, yeah? Lupus, SLE?
Sir, I have kept it. It will be down farther down the line because she did not give any history suggestive of systemic involvement or any history suggestive of features of lupus. But since she is a young female and presented with AKI during pregnancy, so deep down, sir, I have kept it as a differential, sir, down the list. It is not very likely. Yes.
See, for the sake of keeping the differential diagnosis is not correct way. Basically, you must have some pointers favoring that no, this patient is looking like SLE, have the features of the SLE in the past, or presently there was some feature suggestive of the SLE. Then only you can keep the differential diagnosis. So So is there any pointer which favors that no, this patient has a lupus SLE, or is this the presentation of SLE during as a cause of brachy?
So pregnancy can, she was not having any features of or signs suggestive of SLE, but in pregnancy sometimes if she had been having SLE, it can aggravate during pregnancy towards a so.
But was there any features of the SLE aggravation?
So acute onset of renal failure and sudden anuria. So it is less likely, sir. But we just cannot.
If there is no feature suggestive of systemic lupus, then we should not keep just the differential diagnosis for the sake of some. So, but keeping anuric patient, pregnancy-related AKI, then making the diagnosis of SLE without any systemic features of the lupus. It is not usually, you cannot explain your.
So it is one of the secondary cause of TMA, and lupus nephritis can be the initial presentation in 20% of the patients.
So uncommon, rare presentation can be there, but what are the features of SLE do you think that aggravates during pregnancy? Suppose patient had SLE predisposition during pregnancy, you say that it aggravated.
So there can be worsening of hypertension, can be there, worsening of proteinuria. So renal function, accelerated loss of renal function, derangement of renal function.
So do you think this is simply the preeclampsia, and that led to all these problems?
So in her antenatal checkup, she was never told that she was hypertensive. Even during the surgery, she was not found hypertensive. So hypertension was never there, sir. So it is less likely, sir, preeclampsia. No history of hypertension. And sir, no history of edema was there, no frothuria, no complaints, sir, before the delivery. So that's why preeclampsia is not likely, sir.
Okay. So can preeclampsia or eclampsia develop after delivery or during the peripartum period?
So in very few percentage, in 1 to 2%, maybe it can rarely develop after the delivery, sir. So rarely, sir, that is not
common, but everything is uncommon in your patient. So usually not, but the patient, it is possible. Patient has a very good antenatal checkup that you are telling, huh?
Yes,
so during that period, patient did not have a hypertension, so you are not thinking of. But can eclampsia or preeclampsia, severe eclamptic features develop in peripartum period or postpartum?
Sir, yes, sir, it can. Rarely it can, sir.
So what are the features here that suggest no? You already told that the patient had a very severe hypertension after delivery.
Yes, sir.
That was there in the finding, no? So hypertension was there. The patient had a seizure also.
Yes, sir.
So what else you want? The patient required blood transfusion. So would it be help?
So it is not matching with the timeline of presentation, sir. That is one thing. It is sir, less likely. So I can't definitely say that, sir. But sorry, sir, I can't say that. But it should have help, or preeclampsia is more likely if they are present before the delivery, for the birth of the baby. But sir, I had read it can present in very few patients just after the delivery. But sir,
so uncommon thing. This presentation It is uncommon to have this within 48 hours of the delivery, the patient becomes NUD. So usually this is not the clinical features of the HELP. It is fine, but hemolysis, elevated liver enzymes, and low platelet. Usually you can get many things after investigation or examinations, but it is possible blood transfusion you are telling, so it would be because of the hemolysis also, that as like it is in hemolytic uremic syndrome. Elevated liver enzymes and low platelet you don't have. That is the criteria for low platelet for making the diagnosis of hemolytic uremic syndrome also. What is uncommon here is usually the renal failure. Degree of renal failure is usually not that severe. Anuric presentation is uncommon. So that might be the leading questions to you, whether this is there, the possibility. So anuric presentation is uncommon in HELP. So how many HELP are associated with preeclampsia?
Around 10 to 20%, sir, roughly.
10 to 20%. नहीं आप उसको पढ़िए ठीक है. So you should have this association of preeclampsia with HELP. So how many percentage of the patient of you are taking all patient of HELP, then 70% patient would have these preeclamptic features, some preeclamptic features. But overall, preeclampsia who present as the HELP is only 30%. But 10 to 20% is less.
Okay.
So, but for the broader spectrum, clinically, till I think till you have biopsied the patient, you have the differential diagnosis of pregnancy-associated HUS plus ATN. ATN must be one differential diagnosis.
Okay.
How ATN post-delivery is different than normal ATN happening because of the simple gastroenteritis, loss of blood. How ATN post-delivery or post-cesarean is different from ATN happening because of the simple blood loss during road traffic accident.
So ATN usually after the pregnancy is severe and it might lead to, there are higher chances of leading to necrosis, cortical necrosis.
So you might have seen so many road traffic accident every day during your MBBS days or in emergency. So much of the blood loss, a patient do not develop even AKI. Many times, you just resuscitate and patient recovers. But it is not so in pregnancy associated and post-delivery loss of the blood and hypotension. So why this happens? So after delivery, patient develop very severe AKI, even with a small amount of the blood loss.
So because of the physiology of the body is changed at the time of pregnancy. The renal plasma flow, the size of the kidney increases to almost 1.5 times. The renal blood flow increases. So that could be one mechanism. If there is a fall in volume, it leads to a much worse ATN.
So what is the impact of blood loss or hypotension? Why patient, pregnant lady do not compensate so rapidly? One, you have told that there was some changes during the pregnancy, physiological changes happens. The kidney is fully compensated. In large kidney, lot of increased blood supply. Usually, GFR is usually high during pregnancy, so serum creatinine value.
Yes.
So blood loss cause a sudden aggravation of kidney injury. So why this happens? So the patient has good perfusion, good blood, but a small amount of loss. Usually that much loss is not required to develop pregnancy-associated AKI, as happens in simple road traffic accident, severe hypotension. You give the blood, you give fluid, the patient starts passing urine. But here it does not happen like this when in ATN.
Okay, sir.
So why this will happen so? One thing you had told us the fully compensated. Was there any impact of hormones, hormonal changes?
So progesterone usually causes decrease in peripheral resistance, causes decrease in peripheral resistance.
Yeah. So vasodilatation happens because of the progesterone. Progesterone is at the peak during the peripartum period during the delivery. So that is the one. Any other hormones which play a role during this period? What about relaxin?
Yes, sir. Relaxin, sir.
Relaxin is another hormone which is at the peak, and that is also the dilatation of the smooth muscles of the vessels and almost vasodilatory effect. These two hormones at the peak during the peripartum period. So loss of the blood. So under this effect of this hormone, usually there is loss of the compensatory mechanisms. Blood happens, but compensatory response of the contraction of the blood vessels are relatively poor during the pregnancy or postpartum period. So that is the one mechanism. What else? What else? Do you think any evidence that suggests that endothelial cells had different response during the pregnancy than normal populations? Any phenomenon you remember? Have you read any phenomenon? No.
Sir, I did not get it, sir.
Endothelial cell response of the pregnancy. During the pregnancy, is it different from endothelial cell response of a normal person?
So there is less.
Usually less, or other way around.
No, sir.
What we can do, we can finish off your examination and then we'll come back again on the differential analysis. Finish off your examination.
Sir, in general examination, my patient is alert, conscious, cooperative. She's having decubitus of choice. Her build is average. Height is 163 centimeter. Weight is 54 kg. BMI is 20.3 kg per meter square. She has mild pallor and mild ankle edema. There's no clubbing, cyanosis, jaundice or icterus. Neck veins are not engorged. Neck glands are not palpable. She has a right temporary IJV HD catheter in situ. In skin, she has few purple to brown colored patches over arms and legs. And radiocephalic AV fistula is present in left forearm with palpable thin and audible bruit. Pulse, she has 86 per minute, regular. It's palpable in all peripheral pulses. No radial or radiofemoral delay, and condition of the arterial wall is normal. Blood pressure is 144 by 90 millimeter of mercury in right upper arm in sitting position. Respiratory rate is 16 per minute, regular. So, sir, in urine dipstick, actually she was passing very minimal amount of urine. But in urine dipstick, there was 1+ blood and 2+ protein. And in fundus examination, there were few dot hemorrhages seen.
You have told 200 ml urine.
Yes, sir. In systemic examination, in cardiovascular system,
so protodia was there. So protodia was there. Deep strips, what you are talking about?
Sorry, sir.
Any protodia was there?
Sir, in dipstick there was 1+ blood and 2+ protein.
1+ to 2+.
So 1 plus blood and 2 plus protein.
1 plus blood and 2 plus protein. Okay. Okay. Go ahead. Any systemic findings, systemic examination, cardiovascular?
So systemic examinations were more or less within normal limits. So nothing abnormal was found. Heart sounds were heard. There were no added sounds or murmur. Respiratory sounds were present bilaterally without any adventitious sounds. Abdomen was soft, non-tender, and there was an elusive scar was present. There was no audible bruit. And CNS examination, a GCS was 15 by 15. Cranial also within normal limit. Hair functions were normal. There were no sensory or motor deficits.
What are the important things postpartum you should see in examination?
Sorry, sir.
What are the important things we should do in examination in a Praki, patient with Praki? Anything you have told us that there was LSCS scar.
Yes, sir. Sorry. So we have to look for the signs of, say, if she has any pallor or edema or jaundice, which was, or any bleeding manifestation, if she has any presence of ulcers, rash.
What is important?
Reticularis, anything, sir, like that.
You have not told us what the height of the fundus. That is important. So anybody will like to know about that. What is the height or involution process is fine or there is some problem. And then, yeah,
it was just palpable near the brim of the pelvis, sir. It was just palpable.
So that should be there. Whether this is the normal involution of the uterus is happening or not. So that should be the findings. And anything about vaginal discharge?
So that I did not check, but she did not complain of anything. No history was there, but I did not check, sir.
So have you asked during your history whether this is important?
Yes, sir.
How the vaginal discharge history is going to help you in making some differential?
Sir, if there is any foul smelling discharge, that could suggest infection and that could lead to septic AKI.
So you should know about the lochia is other important things findings. If you are presenting a case of pregnancy associated AKI, we must ask about whether this vaginal discharge is the normal or is there any abnormal discharge, poly-smelling lochia, because post-delivery, these things are important. History sometimes gives you some clues to your diagnosis. And sometimes the diagnosis is very obvious. Anyone will say, no, this patient had HUS, developed NUD patient. So that is fine. But the way of asking the history and the examination should be oriented towards other differential diagnosis also. So,
yes.
So is there anything different in your examinations that suggest helps you in making your differential diagnosis strong? So still after you're finishing this examination, so what is your provisional diagnosis and what is your differential diagnosis you want to keep and you want to remove?
Sir, one finding in examination was there were few skin rashes, a few purple to brown colored patches were found over the arms and legs that could suggest bleeding or bleeding manifestation. And in fundus examination, there were few dot hemorrhages. So that goes in favor of hypertensive changes. So she had uncontrolled hypertension. And along with this, sir.
Hemorrhage was dot block?
Yes, sir.
Okay. So you have done yourself?
Yes, sir.
So what is the common type of the hemorrhage, eye hemorrhage because of hypertension?
Sir, flame-shaped dot blot hemorrhages.
How dot blot hemorrhage is different from flame-shaped hemorrhage? Why this happens so? When you say dot blot hemorrhage,
you have some specific things in your mind, or either you can say some retinal hemorrhage is there. If you are talking about the dot and blot hemorrhage, then you are making the diagnosis of what is dot, what is blot. When they write, any ophthalmologist write this is dot and blot hemorrhage. So what is dot and what is blot?
The pinpoint, shaped hemorrhage, sir. Pinpointed.
Yeah, I'm just making you clear that dot and blot hemorrhage is very specific findings for diabetic retinopathy. Dot is the microaneurysms. Usually you see through the fundus, so that is dot. And some of these microaneurysms ruptures, and that gives the appearance of the blot, like the blotting papers when you keep this. So that is very specific. You are telling dot and blot hemorrhage because of the hypertension. It is a very uncommon finding. It might be the diffuse retinal hemorrhage, but it could not be the dot and blot kind of thing. So you can say that some retinal hemorrhages you have noticed, or specific to hemorrhage specific to high blood pressure are usually because of accelerated hypertension is mainly flame-shaped hemorrhage. So why there is flame-shaped hemorrhage in hypertension?
I don't know, sir. Can't say that.
Flame-shaped hemorrhage happens because this type of hemorrhage happens in nerve fiber layer. So whenever there would be a nerve fiber, is the bundle of the capillary's life. So it passed through the capillaries. So that indicates probably the flame-shaped, really hypertension, nerve fiber layer. Usually mostly seen in accelerated hypertension or severe hypertension. Or otherwise you can go away, there are some retinal hemorrhages are there. Don't say this is dot and blot hemorrhage. Dot usually indicate if this is there, there might have some other differential diagnosis you must have. So now the questions comes, you have your different provisional diagnosis after the finishing examinations remains the same, or you are excluding something or coming with some other differential diagnosis.
Sir, I would like to add severe ATN in the differential diagnosis, and I would like to remove the lupus nephritis one.
Okay. So you want to remove lupus and you want to bring severe ATN.
Yes.
Yeah. So that's fine. And usually you must have this severe ATN. I always see that should be the one differential diagnosis, but it is possible that after all investigation, every examinations, it is ruled out. When severe ATN can be associated with cortical nephrosis. So, yes. So it is not that the finding of the only cortical necrosis in biopsy is telling that no, it was only HUS which caused this problem. So it might be associated severe ATN. So now you have done this. So now coming back to, is there any investigations available, Dr. Pratik? We can ask about the investigations, or we can go back on.
Yes, you can ask about the investigations also.
Okay. So how will you investigate this patient? Now you have the chance to investigate. You have done the examination, done the history. So how you are going to investigate?
Sir, baseline investigation regarding hemoglobin WBC counts, platelets will be seen. Peripheral smear, I will like to see reticulocyte count to see for the markers of hemolysis like reticulocyte count, LDH, serum haptoglobin levels, and liver function test to see for liver enzymes and bilirubin levels. And so then she's not passing urine, so that will not be done. Sir, then immune related disorders I would like to rule out. So for that, the complement levels, C3, C4, autoimmune markers like ANA levels, then sir, APLA profile, sir, all this investigation. And apart from this, I will see for the coagulation parameters, INR, PTA, PTT, this I will see. Sir, and then...
So could it, let's come back to your differential. Could it be, you have told an APLA parameters, yeah?
Yes, sir.
What APLA parameters you like to know? Specific?
So there are 3 anti-cardiolipin antibodies, anti-beta 2 glyco GPI, and lupus anticoagulants, sir.
So could it be a DIC still?
So DIC will be more severe in manifestations, as the DIC will be more in. So there was no history of suggestion of any infection or sepsis. DIC will be usually related with any infection or sepsis parameter, and then the so the renal dysfunction is not so severe in DIC, and there will be other manifestation like so bleeding manifestation. There will be so vitally the patient will be more unstable in that case, sir. Coagulation
What are the
parameters will
points?
be very much
So what
deranged.
are the points against DIC? Patient has increased BP that you are telling, huh?
Yes, sir. So
What else?
vitally the patient will not be the AC patient will be unstable.
Can pregnancy DIC happens without evidence of the severe infection?
Sir, if there is a if there is abruptio placentae, sir, that can cause DIC because of loss of coagulation factors, sir.
So one is abruptio placentae. What else?
So septic AKI can cause DIC. Septic sepsis and pure pleural sepsis can cause pure pleural sepsis, and sir, abruptio placentae and pure pleural sepsis, these two can cause DIC.
Do you think a written product of conception can lead to DIC like?
Yes, sir. Yes, sir. Yes, sir. Written products can also lead to DIC, sir.
The postpartum period written product of conception can lead to this. Sometimes intrauterine death remains dead fetus for longer times that can induce DIC-like pictures without any evidence of infection or sepsis associated DIC. So in pregnancy, DIC could be little different from DIC which happens because of the sepsis and infection. So usually it is a little different. So abruptio placentae kind of the features, if that was undetected many times, there is no very pertinent follow-up. Abruptio placentae can have this concealed hemorrhage. It is possible that it might not be the obvious vaginal bleeding. So concealed hemorrhage is there long times and can have developed DIC. So how you say here the condition DIC versus you have HUS. So how you will differentiate these two conditions? In DIC also you can have the low platelet count. You might have the cystocytes, because macroangiopathic hemolytic anemia can be there in DIC also. It can be in HUS also. Okay.
Sir, in DIC, the coagulation parameters will be quite deranged, sir. So fibrin degradation, so we can investigate for it. We can see for the fibrinogen levels and fibrin degradation products, and that can guide us in differentiating DIC. And
so definitely one parameter is always that most of the times DIC is associated with increased INR. INR is usually increased. PTA, PTT are elevated as compared to typical HUS. So many times that he gives you the hint. So, but again, DIC is important differential always there in patients of brachy. So can be because of non-infective causes or can be infective. So we should have the orientation of the history towards that. We are making some of the differential and excluding these during the examination and history taking. So DIC is sometimes mimic like HUS. When you send this investigation, then you would have the cystocytes You might have but one clinical parameters or investigational parameter is INR, PTA, PTT. So that we must keep in mind. So now coming back, we are talking about the endothelial cell function during pregnancy. Are you aware about the Schwarzman phenomenon? Schwarzman reaction during pregnancy?
No, sir.
No.
sir.
Schwarzman reactions are usually the endothelial cells during pregnancy was hyperreactive, had hyperreactive response. So there was one mice study already happened that has demonstrated with the injection of endotoxins. When you gives endotoxins, pregnant lady had pregnant mice has very severe vasoconstriction response compared to the normal. So endothelial cell functions is very much deranged during the pregnancy. So this is one of the reasons that is thought to be that the patient, even with this a small amount of the loss of blood, endothelial cell functions during the pregnancy is hyperactive. So usually a response in such a way that leads to that contribute in developing AKI. So read about the Schwarzman phenomenon during the pregnancy. This is basically the found during the experimental study with injection of endotoxins.
Okay.
So that many times it has been shown that response of endotoxin is such that the patient might have the diffuse intravascular coagulation of thrombosis in renal macrocirculations. In pregnant mice, this has been demonstrated. So Schwarzman phenomenon is the other phenomenon which again contributes in developing cortical necrosis. It is an important contributory part of the cortical necrosis physiologically.
Okay,
One is the compensatory mechanisms, hormones, and others that is not fully compensated. So usually the ATN which happens usually more severe than the normal populations in blood loss due to other causes, or one of the important phenomenon which has been demonstrated in mice study was response to endotoxin, Schwarzman reactions. So this is the reason why the pregnancy associated AKI is little different from. So you have already done the biopsy. Biopsy finding, is there anyone has this biopsy finding? What was the biopsy finding?
Sir, in first biopsy, out of 5 glomeruli, 4 glomeruli had fibrin thrombi in them, sir. And the immunofluorescence, there was no deposit in IF. Only light microscopy, there were out of 5, there were in 4 glomeruli, there were fibrin thrombi seen.
The first biopsy. He has two biopsies, yes.
And sir, in second biopsy, there was almost diffuse cortical necrosis, around more than 80%.
What was the gap between the two biopsy?
So the first was done at day 8 and the second was done at 3rd week. Roughly around, sir, 12 to 13 days gap was there, sir.
So in first, there was only fibrin thrombi, first biopsy.
And sir, there were, fibrin thrombi was there, sir.
And the second biopsy, after the gap of only 8 days, the patient has diffuse cortical necrosis. So why the first biopsy has been done? Will you like to do first biopsy 5th or 6th day of post-delivery AKI?
Sir, I did not. So why first biopsy was done?
That was done within how many days of the delivery?
Sir, on it was done, sir, on 8th day after admission. So that would be around 10th day of post-delivery, sir.
When you should do the biopsy for making the diagnosis of AKI? Usually, even in normal, suppose you are the physician, patient comes to you, would you like to do biopsy on 8th day? What is the normal course of the ATN? Because you have not made the differential.
sir, 60 to 70% of the ATN they usually recover by 3rd week.
So it is possible that if you must have given some time to observe that whether the patient has self-recovery, whether the patient has a ATN.
Usually, most of the times, biopsy in AKI usually indicated after 2nd week, either in 3rd week when there is no chance of recovery. You so see the normal course of the ATN is not followed until and unless the investigation is suggestive of HUS is a clinical diagnosis or histological diagnosis. Hemolytic uremic syndrome.
It is a clinical diagnosis, sir.
Biopsy is not a clinical diagnosis. Does not require that much of the biopsy to be done in so hurry. So if you are fulfilling the clinical diagnosis is there, then we should wait for. But 2nd biopsy is justified in the 3rd week. If there was no recovery, patient remain anemic, then we can go for this biopsy. So that is fine. But 6th, 7th day of the post-delivery doing the biopsy, usually clinically, yeah, I will not say this is the appropriate time to do. But 2nd biopsy is justified. So 2nd biopsy was showing diffuse cortical necrosis.
Yes, sir.
So that was the finding.
Yes.
So what is the histological hallmark of HUS?
So there will be diffuse, there will be fibrin thrombi, sir, in the capillaries and small arterioles. It can clog the lumina also. And so there can be proliferative changes, but they are not very common. So usually fibrin thrombi are likely seen, sir. They can be associated necrosis. Sir,
is there any other way? Is there any other way to confirm?
If the disease is there for some time, we can see changes of glomerular ischemia. There can be retraction of the glomerular capillary tufts.
So fine, it is, you are demonstrating fibrin thrombi. It is fine that it is suggestive of HUS. Whether there is any other way other than biopsy to make the diagnosis of cortical necrosis. Sort of, sometimes the patient does not want to go for the biopsies.
So to see for cortical necrosis, CT can be done, sir. Contrast enhanced CT can be done to see for the necrosis.
What finding you will see?
So there will be cortical rim sign.
What is cortical rim sign?
So the contrast will not be it will not take the contrast in the cortex. The cortex will not take the contrast. The medulla part it will take, sir. So there will be a rim-like differentiation between cortical tissue and medullary tissue.
Okay. So, but definitely, if condition permits, you can go for this sort of this rim sign. You can demonstrate why there is this rim sign. What is your explanation for this rim sign? Why it appears?
So because the contrast is not taken by the cortical tissue, sir.
Contrast is not taken by cortical tissue.
Yes,
but it is taken by?
It is taken by the other rest parenchymas. So the cortex is there's a demarcation between the cortical tissue and the rest tissue.
So suppose this patient has this much of cortical necrosis. What is your plan?
So since she is not passing urine adequately, we'll have to continue dialysis in this patient.
What is your management plan? Yeah, dialysis, it is fine that dialysis, you are going on dialysis. What is your plan for this patient wants a definitive diagnosis, a definitive treatment? So patient diffuse cortical necrosis is there. Patient is still anuric at the end of the 4 weeks or so, 4th week. Then final treatment, patient wants to go for transplantation. Will you like to go? Will you like to go for?
Yes, sir. Transplantation can be done, but before that, sir, complete evaluation of the patient has to be done to see for the actual cause of atypical HUS, to see for any genetic abnormality or any the complement defect has to be.
So how will you investigate that one? Just be fast because we don't have time now.
So we can do a genetic test, or we can check the factor levels in the blood, sir. Or
how will you approach this genetic test? What will you do? What first?
So the complement panel of investigation is there. So the most common genetic abnormality usually is complement factor H related. So complement factor H mutation.
Usually postpartum HUS, what is the first investigations to be done? And why?
Sir, blood investigation.
Yeah, first money. What do you want to
complement? So complement levels will do first. C3, C4 levels.
What is about the ADMTS? What is the present recommendations to work for?
So any patient presenting with a picture of thrombotic microangiopathy, will check for the RMTS 13 level. If the activity is if the activity is more than
first investigations that is suggested and recommended is ADMTS 13 level. So if you rule out this is normal, why it becomes important during pregnancy?
So, because it can precipitate. It can during the second or third trimester of pregnancy, RMTS levels can go down.
During the pregnancy, usually those who have the partial deficiency of these enzymes gets aggravated during pregnancy, and that can predispose these patients for developing. Some patient might be TMA, typical birth form, or HUS like picture. So first things to be done, and then you go for the other complement dysregulations.
Yes, sir.
What other complement dysregulations?
Sir, complement factor H related proteins, complement factor I, complement factor B, C3, MCP levels, thrombospondyl.
So other complement factors related gradients you can go for.
Sir.
So that you should test for that, and then you can go for, because the patient needs the final answer to go for the transplantation. So suppose some factor H related abnormality came in the picture, what will you do?
Sir, if it is related to factor H, the combined liver and kidney transplantation can be done because factor H is produced by the liver. Otherwise, sir, we can use eculizumab in post-transplant, in before and after the transplant. Under eculizumab cover, we can proceed with the transplant, sir.
You should read about these courses, and we don't have too much of the time. Probably it is 7:10. So read about these complements and how you are going to approach about this, and when combined liver kidney transplantation, when only kidney transplantation. If you are going for the kidney transplantation, then what precautions you will take? What is the role of the eculizumab? So do you think eculizumab will be required?
Sir, atypical HUS, it has been eculizumab is the it's been recommended these right at present in atypical HUS because it has been shown in studies that patient even after transplant, those who continue with eculizumab therapy, the graft survival is better in them.
So read about all that. What are the different side effects? How you are going to take care of vaccinations before giving eculizumabs, meningococcal infection, other
meningococcal infections.
So all these you should read about. So, Dr. Pratik, can we stop here? It is 7:10.
Yes, if you want to ask one or two, you can ask. Otherwise,
I was just giving him hint that he should be prepared. Finally, for these patients will require definitive therapy. Definitive therapy would be if diffuse cortical necrosis. How many patients with this kind of this passive cortical necrosis becomes dialysis independent? Are you aware about any study, Indian study? How many percent of the diffuse, or you might have seen many patients with this diffuse or patchy cortical necrosis usually becomes dialysis independent after some time. Urine output improves and patient becomes dialysis independent.
So very few. I can't exactly say the percentage, sir, but it is very few.
But acute diffuse usually do not recover whether this was the patchy cortical necrosis, because the first time there was only fibrin thrombi. So I think patient would have the patchy cortical necrosis rather than diffuse cortical necrosis. First biopsy was not showing that much of the diffuse kind of things. So it is possible patchy cortical necrosis. Urine output is 200 ml. Gradually, over the times in the 6-month period, it has been observed that those patients who show some of the increasing amount of the urine output, 25%, 30% patient becomes dialysis independent by the end of follow-up of the 6 months. So it is not uncommon. So you should observe this. Then say me if the patient had predisposing factor for HUS, why this patient did not develop during pregnancy? This complement related HUS. Why after delivery?
So
suppose
surgery could be one of
you are thinking of mainly complement related dysregulation, as I understand. Fine?
Yes, sir.
Here you are thinking of the HUS happens mainly because of?
So complement related disorders.
Complement related disorders. Fine. So why this did not happen during pregnancy?
So one. So
during
cesarean
pregnancy,
section surgery could be one stressor, sir, which precipitated.
You have already told me that pregnancy was also a first hit stress. So but delivery. So usually it precipitates pregnancy related AKI HUS is a little different from other HUS. What you see, placental bed has the many decay accelerating factors, CD59, which keeps check of the inhibition complement system. So once the placenta is delivered, so this inhibitory factors go off and the patient has the activated complement system, which is already there ongoing in the body, and the patient has the first aid. What you see in most of the times in the pregnancy associated HUS, usually the patient go rapidly into hematological remissions. You will see it requires 1 or 2 blood transfusion. Patient after 2, 3 weeks or 4 weeks becomes hematological remission. Platelet starts coming up, platelet becomes normal, hemolysis go off. So hematological remission in this kind of the HUS is rapidly achieved usually. And by the time, because of this very high degree of this activation and other mechanism, compensatory mechanism are lost, so patient has cortical necrosis by that time. So renal remission, it is very difficult to achieve, but hematological remission, without giving eculizumab, without giving any therapy, usually the hematological remission is achieved. But by the time you have lost your kidney, so that is a totally different phenomenon. So placental delivery, where inhibitory factor of the complement go off, and there is acceleration of the complement system. If there is genetic predisposition for these patients, this leads to this kind of the situation. So usually this happens so. So I can stop here, Pratik?
Yes.
Yeah.
So is a formal thing we ask how he performed and whether he should pass in the examination or require some more one. And before that, I can make a summary of the class, a small. What is your impression regarding the student? And then I'll give a small summary.
You are asking me?
Yes, as examiner.
He has done fairly well. Most of the things he knows the basics, but examination is a little different ball game. Sometimes you know the diagnosis and you are jumping on the diagnosis. So approach should be such that you always had differential diagnosis, some points in favor, some points in favor, because your patient was very obvious that no patient would have this patchy cortical necrosis or diffuse cortical necrosis. Some patient become anuric 2 times, biopsy has been done. But at the level of the history, when the patient comes, when the first presentation shows you, what would be your differential diagnosis? So 1, 2, 3, 4. So there must be some points in favor of keeping each differential diagnosis. Then only you can. It is possible that the many pointers would be against this differential diagnosis. Like if I could have been the examinee, I could have kept this severe ATN in this differential diagnosis, because there are many other things happens during the very surgical periods that can lead to ATN, severe blood loss and ATN, particularly in pregnancy. It is little different ballgame. So that is my impression, but overall your knowledge is very good. You have your approach was good, but definitely stage wise, because when you are presenting the case, patient is already seen by many of us. Many times diagnosis is very obvious. We jump on the diagnosis, but examiner is not interested in knowing the definitive diagnosis. How you are approaching patient, that is important, in my view.
Yes.
Yes. Thank you, sir.
Yes. There are some questions in the
Chat box.
chat box. Yes. One
Dr.
is-
Anuradha Datta would like to answer these questions. Probably might be related to this lipopolysaccharide
yes.
injected result in inflammation, coagulopathy. I agree. Dr. Pita has written this. So we have already discussed about this. So you should know about this Schwarzman phenomenon, and many times this is usually commonly asked questions if you are going for pregnancy associated AKI. Rashri Benares, in how many percentage of lupus nephritis first presentation occurred in pregnancy? So in how many percentage of lupus nephritis patient first presentation occur in pregnancy? I'm a little confused with this question. The lupus nephritis patient usually first time during pregnancy, uncommon to have this type of the presentation. Usually aggravation happens like in the glomerular form, right? You might have stage 3 or diffuse proliferative glomerulonephritis like pictures. Pictures is not like this. So you would have the diffuse proliferative glomerulonephritis kind of picture if aggravation happens. You keeping the diagnosis of SLE must have some background that probably this patient had SLE, then you are keeping the differential diagnosis. Otherwise, I don't see there was a requirement of the lupus kind of. If there were any feature, even subtle clinical features at time of presentation is there, then you must keep. Otherwise, it was not required. Pregnancy, we made a protocol of doing after second week. Biopsy probably she is talking about Pita. Usually, biopsy is usually done in third week, third or fourth week, because you have to give the time to see whether this was only the severe ATN or because HUS is the diagnosis of clinical diagnosis. So based on the clinical diagnosis, you can make this. So definitely I agree with Dr. Arpita that usually 3 weeks or after 3 weeks, we can go for the biopsy. Peri-transplant eculizumab may be required to cater the AHUS precipitated by stress during the pregnancy. Definitely, if you have available. But one thing is, we have seen recently 3 patients who have anti-factor H antibody associated HUS during the postpartum period also. Usually, it was thought that factor H antibody associated HUS are only seen in adolescent or childhood kind of the HUS. It is not true. Even in India, even the adult patients might have the anti-factor H antibody associated HUS. So there you can go away without eculizumab. If autoimmune mediated hemolytic uremic syndrome kind of presentation is there, you can go away without eculizumab, giving prednisolone and giving mycoplasma or induction kind of thing. So sometimes it is little different in Indian scenario. But definitely eculizumab will be required cover if there is some complement dysregulation. You find some complement factors. A 50-year male with CFS mutation with biopsy showing TMA fibrin thrombi in 4 out of the 10 glomeruli, no IPTA progress to SID may. I know the transplant prospects. The transplantation always can be done, but you must have the fear of the recurrence in the graft. And usually, whenever we are doing now this kind of the transplantation, we are prepared. We must have some medicines to control this activity. Keep in a store the eculizumab, and we have recently used in one patient transplant iptacopan because that was the drug under trial was available with us, and we have taken care the recurrence of this HUS, the iptacopan. So these are some. It is likely that by the 2-3 months, iptacopan would be available in India. Eculizumab also might be available by the end of this year. So that might, definitely that is required if you are demonstrated CFH mutations. Chances of recurrence is high, and we must prepare yourself for taking care post transplant. So that these are the questions. So
okay. I'm just making a summary of your class. So, Dr. Tanmay, you have done reasonably well. You presented a postpartum case of acute renal failure. Initially, your examiner has asked you about your provisional diagnosis and initial diagnosis. And depending on your answer, he has asked, why are you suggesting TMA as your first diagnosis? Why are you not considering as a simple AKI or the ATN, which is a far more common disease? Basically, why not it is ATN, and what is especially a severe kind of ATN? And then he was asked what is the normal blood loss in cases of the normal LUCS or a normal delivery, and how much is that? And what is the clinical evidences of hemolysis in this patient? Because hemolytic uremic syndrome is a triad of hemolysis, renal failure, and low platelet count. So how from the history you can extract the evidences of hemolysis? And from the history, you should keep a severe ATN. He repeatedly suggested that because there may be a blood loss which may be unnoticed, there may be an undetected hypertension for a longer period, there may be the surgical history may not be clear every time. He asked about the different causes of the anuria, especially in the pre-renal and the severe ATN cases. You may not get a severe anuria, but in the renal causes, yes, there are the causes of anuria in some patients. And he asked about your diagnosis of antiphospholipid antibodies. What are the points in favor? What are the criteria of APLA syndrome which you should read? Is there any definitive or essential criteria for that? Should there be a compulsory history of arterial or the venous thrombosis? And what is the position of the accelerated hypertension in the patients of the APLA syndrome? What are the differences between the primary and the secondary APLA? And he has suggested one important thing: just for the sake of keeping a differential diagnosis, you should not keep any differential diagnosis. What do you think is necessary for the patient? Just keep that. In this situation, I reminded you what is the scope of keeping SLE as a differential diagnosis in this patient, because lupus nephritis presenting for the first time as AKI postpartum is not very common. What are the features that of lupus that is aggravated during pregnancy? And what are the he has also asked you why this is not a case of simple pre-eclampsia or an eclampsia. Can eclampsia develop after delivery? And in your patient, is it possible? He has asked about the HELP syndrome. What are the components of the HELP syndrome, and how much cases of the HELP syndrome are associated with the pre-eclampsia? And you just reminded you the percentage which you have told it may be slightly higher. ATN in the post-LUCS, why it is different? ATN happens, but why it is different from other causes like gastroenteritis or road traffic accident? You say so many patients of road traffic accident, but they not develop that kind of severe ATN. And impact of blood loss in pregnant patients. He has asked about the role of hormonal factors, particularly the progesterone, the relaxin, and what will be the other causes. Here comes the role of the endothelial cell response in pregnancy that may be slightly different compared to a normal person because it is a state of vasodilatation. And then he asked about the examination finding, and after examination finding, this is finding up. You asked you about the what are the things you should look in cases of the Praki to which can give you a diagnosis. Where you missed about this fundal height, that is one important thing. Whether the uterus is involuting in time, whether there is a vaginal discharge, that kind of vaginal discharge that can give a clue to the diagnosis. Why it is important, And local history is also important in the postpartum period, that you should ask at least, even though you cannot examine. Any other thing in the examination and for provisional diagnosis, he asked you whether you should want to change your provisional diagnosis or not. Again, he given emphasis on the acute cortical necrosis followed by a severe ATN. You mentioned about the retinal hemorrhages, so he corrected you for not mentioning dot and blot hemorrhages, which are very much characteristic of diabetic nephropathy, microaneurysm and their rupture. Rather than you should describe a flame-shaped hemorrhage, which is which has more correlation with the hypertension, particularly accelerated hypertension. Then in the investigation, he asked you about the APLA parameters. What are the APLA parameters, and what are why it cannot be an DIC? Because DIC may have a similar picture, and what are the differences? What are the things that happens in the pregnancy which causes a non-septic DIC? Particularly if there is an abruptio placentae, there is a retained product of the placenta, the product of conception or IUFT, you can get a DIC that may not be related to the sepsis. Then how do you differentiate with both the condition HUS and DIC may be present in the postpartum period? How to differentiate? What is the role of these coagulation parameters, particularly PT, INR, etc.? Because both of them can present with a low platelet count and evidences of the hemolysis. He emphasized about and asked you to read more about endothelial cell response. That is a newer concept, particularly Schwarzman phenomena. He explained in detail what is this is an hyperactive response of the endothelium. Particularly in the mice model, there are the studies which showed that there is an hyperactive response that precipitates this microcirculation, that affects this microcirculation of the kidney and precipitates this acute cortical necrosis. Then why this first biopsy, after why the first biopsy was done on the 8th post-operative day? Because usually asked you what is the ideal time of doing an biopsy for the AKI patients, usually after second week and the third week. And what is the normal course of the ATN? In this context, he has asked you. HUS, whether it is the clinical diagnosis or histological diagnosis. He asked you about the histological hallmark, clinical features and diagnosis, and the cortical necrosis diagnosis without biopsy, whether it is possible or not. What are the other investigations? What is the cortical rim sign in CT? Why does it happen? And what is the plan for this patient who was presented with a postpartum AKI with diffuse cortical necrosis and anuria? How do you plan for the transplantation in these patients? What are the basic investigation you should do before transplantation? He reminded you the first line of investigation should do is ADAMTS 13, because this is important during pregnancy, and why it is important. He has also given the explanation. And this is ADAMTS response that is different in the pregnancy. How do you do the complement assays? And suppose this patient has a complement abnormality factor 8 related disorder, and how do you plan for the transplant in such patient? And he has asked you to read detail about the complements, that this is the importance of this testing in the transplantation, what is eculizumab, what are the different dosage, side effects, vaccination required, infection, etc. And then finally asked you about this cortical necrosis patient becomes dialysis independent. He asked you about any Indian study, whether they develop in patients who develop patchy cortical necrosis. We have seen so many patients doing reasonably well with a good urine output without dialysis, the creatinine of 3 or 4. Why the complement mediated HUS that happens after delivery, not during pregnancy, and the explanation. Because of these placental factors, I am not also very much conversant with that, but you should read that. This is an important thing to know. And why they do that, that's why this is maybe the explanation. They go to the hematological remission pretty early compared to the renal remission, and renal lesion is so much severe. So this extensive discussion is completed, is examination. So you can expect such kind of teachers in the future classes also, so that you can learn many and many things which helps you in your, not in your exam, but also in your practice. So that is very important. So we can go to our next part. This is ASCII. You can stay if you wish. That will take 10 to 20 minutes. Or otherwise, you stay. I might request you stay.
Someone is waiting outside. I will meet him and I will come back again to join you.
Okay.
But I will definitely like to thank you for making such a great summary, always as usual. I'm really happy. Even I do not know. Remember that this much of the question has been asked.
my learning. This is that's why I have written. I think this is
Thank
5
you.
pages. I have written 5 pages.
Thank you. Thank you, Pratik.
Thank you very much for this class. Okay.
I just will come back and join.
Okay. Okay.
You can.
Yes. So, Dr. Aniruddha, you can go to the share the screen and go to the OSCE. Tanma, you have to read the problem and give your opinion. That may not be a one-line answer. You can give your opinion, and this will be on something different, which is not discussed today.
Good evening, sir. So my screen is visible.
Yes, the voice is slightly unclear.
Is my voice audible now?
Yes, yes.
Okay, thank you, sir. So we will begin. This is your first question. And we'll go through the question.
A 5-year-old male child is presented with history of poor growth, history of bedwetting, water craving. In lab investigation, hemoglobin is 10.1, total leukocyte count 11,000, platelet 2,16,000, serum creatinine is 2, urea is 55 milligram per deciliter, bicarbonate is 15. And in urine microscopy, albumin is trace, pus 2 to 3, and RBC 2 to 4.
Read it.
On evaluation, height is 102 centimeter, weight is 15 kg, BP 84 by 60. Upon plotting on WHO chart.
What do you see? What is this and what do you see?
So this is a WHO growth chart, which is showing this at the
Yes.
So is that red dot? It is,
yes, it is put like that only every time. It is a WHO chart, and this is the red point is for this patient.
It is below the percentile, third percentile.
So what is your
below
diagnosis? Below the third percentile, you tell.
Yes, sir.
Okay.
So growth retardation is there in this head.
Okay.
Growth retardation is there.
Growth retardation is there. Is it for the growth retardation or some anything you want to add as adjective? It's a very severe kind of growth retardation. Third
Yes, sir.
percentile.
Yes, sir. Severe kind of growth retardation.
And anything about this basic disease? What is the child is suffering from?
So there is history of polyuria and acidosis. Could be renal tubular acidosis, sir.
He is also renal failure also. You just go back to the slides.
As a creatinine was 2. And
it's very common to have a renal failure.
No, the renal failure is not.
It is so.
There is history of polyuria, growth retardation, severe growth retardation, and renal dysfunction.
Yes. Renal failure, some polyuria is there, and growth retardation at the age of 5 years. There are only few diagnoses are there. Okay, go ahead.
This is the weight for age chart.
Yes.
We have plotted according to the weight.
So weight is also below the third percentile.
Okay. So what is your impression? Yes, both height is below third percentile, weight for age is also is very less.
Less, sir.
Okay. So read it.
You gave corrective interventions, and after 1 year, this is the findings. Kindly go through.
Weight is now 19.5. Height is it was 107 centimeter. Hemoglobin is 11.1. Total count is 8,100. Platelet is okay, 1,85,000. Creatinine has increased to 2.7. Answer: albumin is 3.9, calcium is 9.1, phosphorus is 4.8, bicarbonate is 21.
Okay. So what are the things that has been corrected and what is not corrected?
So the serum creatinine has increased, the bicarbonate is corrected, weight has increased, but height is not that increased. The height was 102 centimeter, it is 105 centimeter now.
The child is still in growth failure. Okay.
Yes, sir.
What is the height velocity of this child?
Height velocity.
So when we plot the height velocity, that is the difference between the present and the previous height, in a period, a particular fixed period of time. So when we plot it, this is the plotting of the height velocity of this particular child. What do you see?
The height has not taken place. It is still on the height velocity is not up to the mark. It's
at the 10th percentile.
10th percentile, right?
Yeah. So these are your questions. How will you define this particular state?
It could be related to the metabolic bone disorder related to CKD also, or
Not the diagnosis. What is the definition of this state? This is a growth failure.
Growth failure.
So growth failure.
Treatments available in growth hormones can be supplemented if the patient is.
So
Treatment of the existing condition. Treatment of the existing condition. Treatment for the CKD. Treatment of acidosis. Treatment of electrolyte. Along with, we can supplement growth hormones if the patient is not achieving the required growth.
So you have given the conservative treatment and other this acidosis correction. Still, he is in a state of growth failure, and you have told this is a growth hormone treatment is available. Then what parameters will you evaluate before subsequent therapy?
So the
any investigation we want to do, or there's a pre-therapeutic plan? Okay,
so
go to the next slide. Is it important? Why it is important?
Sir, because the height achieved is, and in case of boys, it is 5 centimeter more than the average height of the mother and father. In case of girls, it is less.
Parental height is given.
$169.
Okay, I will do tell.
It will be around 164, 165.
You can target.
Plus,
Yes,
plus 5, sir.
So-
So it will be around 170, 169, 170 will be the target.
Around 170, approximately like that. You have to actually calculate what is the growth potential, what is the target genetic height of that particular patient, how much it's the deficit. And then comes the imaging. What are the imaging which I have shown? What are these? I may identify and tell us
The left hand side is the X-ray of the palm, and right hand side it is a fundoscopy. In fundus, it looks like the fundus. It is pigmented, likely retinitis pigmentosa.
The palm or extra hand, it is not a soft tissue. It is also showing the bones. You are more interested in soft tissue or more interested in bones?
So the bones.
So why this investigation is done? What do you see, and why the other investigation is done, and what do you see?
In the excess of the bones have not ossified properly. Ossification centers can be seen. So I could not see any erosion or any bony abnormality.
Okay. What is your comment regarding the epiphysis?
Sir, they are not fused, sir. Epiphyses, they are not fused yet.
So is it important before planning a treatment of such patient?
Yes, sir, because the growth potential, we have to see if the further growth can be there or not. If the centers are ossified, there may not be any benefit of the
Right. So
treatment even.
So for that, you need to do this test. Whether you are planning for such a costly treatment, whether the patient will be benefited or not, that is important. Epiphysis, that must be seen before starting a therapy. And on the right side, that has a two-part. One is in your pre-therapeutic plan, and it gives you a clue towards diagnosis.
Sir, IPTH is 387 and vitamin D is 45. So vitamin D is in the sufficient range. IPTH is slightly on the higher side, sir. And the fundoscopy, likely it is retinitis pigmentosa.
Yes.
So, in the history of the patient.
The retinitis pigmentosa will be present. Sorry, sir.
Anything you want to see in this fundoscopy other than so much pigments? You are planning for a treatment, which is a child which is suffering from growth failure, or planning for treatment. You have done the X-ray, you have seen the epiphysis, now you are on the fundus. Is the disc clear?
No, sir. It is.
Margins are clear. There is retinitis pigmentosa, no doubt.
Sometimes you'll end up in a problem if you give a such injection, hormonal injections, and you might precipitate papilledema and patient.
Yes, sir. It can retinal involvement.
Okay.
Optic nerve has to be seen.
Yes. So the optic disc is only clear margin. There is no papilledema. That gives you enough relief so that you can start the next treatment. These two things you need to see before starting the treatment. Okay.
Cause of this possible CKD, what was the possible cause of CKD with this fundoscopy and the clinical history which was given beforehand with bedwetting, craving for water, excessive thirst, growth failure.
Retinitis pigmentosa is associated with the nephronophthisis.
PHP1 type 1 possibly.
Nephronophthisis.
Matching in the age of onset symptoms. Growth failure.
Yes, sir. 5 years.
So
it can present in infantile variants can be.
Juvenile variants possibly.
Okay. Go to next. So if you plan for some therapy, tell us some dosage of the and duration of this.
Sir, I can't. I don't know, sir.
Okay, then I'm going to go to next slide.
Loss follow-up 5 years later presented with ESRD, severe azotemia, initiated on dialysis, height 123 centimeters.
Okay. Now he is on ESRD, still in failure.
Still the growth is, height is not adequate.
Okay, next.
Family wanted a kidney transplant. That's HDB vintage, 3 months, underwent ABO incompatible transplant, mother donor, good immediate graft function, nadir creatinine 0.76, one evidence of biopsy proven acute rejection at 2 months, ACR plus ABMR, post-transplant at 1 year, height 127 centimeters. In CBC, hemoglobin, total count and platelets are normal, 10.1, 8,600 and 141,000. Creatinine is 1.25 milligram per deciliter. Fasting blood sugar is 87, postprandial is 148. In urine routine microscopy, albumin is 2+, and RBC 1 to 2, and pus cell 1 to 2 per high par field.
So what would have been planned if this is not an ABO incompatible transplant?
So what could happen?
It is an ABO incompatible. Suppose it is not an ABO incompatible transplantation, then what immunosuppression alteration or could have been done to this patient? regarding
So
steroid?
steroids can be, sir, tapered early, or the dosage reduction can be. It can be tapered early, or the withdrawal can be attempted.
So in the previous pre-transplant, because it is an high immunological risk, the steroid omission was not done, and it subsequently developed the rejection. That's why steroid was continued. The result is at 1 year, height is 127 centimeter. Okay.
Height is not increased, sir.
So this is the problem. This you can see here. Still, he is now 11 years, more than 11 years of age, but still in the below the
third percentile.
So we have done so many positive things for this patient, but this growth has not been taken care of properly. So this is an important part. Okay, so for that you need to some theoretical knowledge regarding this.
Again, if we look at the growth velocity, it's still below 25% of 25 percentile. So, how will you decide whether you can further initiate any therapy for giving him the catch-up growth?
Growth hormone can be used in post-transplant period also if the patient has not yet achieved the catch-up growth and is expected to grow further. Can be used.
So how do you decide whether he has that potential left or not? Again, you look for the
see for the X-rays and see for the ossification centers if they have ossified or not.
You see, and what is the difference now?
So they look the ossification center, they look mature. They have fused with the
closed. This is fused epiphysis.
Fused with the metaphysis.
So will you be benefited by this growth hormone treatment?
So less likely, sir. I don't think so.
Okay. Next.
So these basically, whenever we are planning for initiating a growth hormone therapy, there has to be some baseline workups. That is, first of all the underlying correctable factors, they need to be corrected. That is, the metabolic parameters need to be corrected. And then you actually have to compare the height velocity at least for a period of 6 months. And then you have to identify whether that patient has a growth failure, that the height is below the third percentile and the height velocity is below 25th of the percentile. In population with in CKD population, the height from 3rd to the 10th percentile can also be considered for this growth hormone related therapies. And when we look at the indications of our indication of patients who can undergo a growth hormone related therapy, that mainly patients with CKD and growth failure, and in certain patients with renal dysfunction irrespective of EGFR, like cystinosis, distal tubular acidosis, or Fanconi's syndrome. Even if you have preserved EGFR, you have to you can plan or initiate on therapy if you have indications of growth failure, because these diseases have an increased preponderance towards causing growth failure. And in certain patients or adolescent patients or in post-transplant patients, you can actually start growth therapy after growth hormone therapy after a period of waiting for 12 months when you have given this period for getting a catch-up growth. And if he is not able to get that because of increased immunosuppression like steroids and everything, then or because of the underlying poor graft function, then you have to plan for a growth hormone therapy. And whenever you are planning for starting, you have to do a baseline thyroid workup, insulin growth hormone like workup. You have to do a fundoscopy to rule out the presence of papilledema, because this growth hormone therapy can cause increased ICP. And also this radiography of left wrist to document whether there is epiphyseal fusion or not. And you have to always check for the pubertal status or the presence of sexual maturation. And again, which you were describing, the formula to calculate the genetic potential of it, there are multiple formulas for that. And we cannot actually initiate growth hormone therapy if you have this closed epiphysis, or if there is presence of severe secondary hyperparathyroidism. Usually, whenever there is a serum PTH more than 500 ml, 500 picogram per ml. So when if you initiate a patient on growth hormone therapy having severe secondary hyperparathyroidism, that actually can result in slipped cap deposition, femoral syndromes, or anything like that. The epiphysis can dislocate. And also in patients who have severe proliferative or non-proliferative diabetic retinopathy, or patients having any active malignancy or something like that, you have to you cannot initiate the patient on growth hormone therapy. And the dosage is usually 0.45 to 0.5 milligram per kg, and the timing is usually at the evening to match the circadian rhythm, and the duration is mainly you have to follow it up whether they are responding well, and if you have a growth height velocity less than 2 centimeter per year when you are the first year of growth hormone therapy, then you have to again cross check to look for any kind of adherence and whether there are other metabolic or nutritional factors which are hindering the response to growth hormone therapy. And we actually stop the therapy whenever there is epiphyseal closure, or whenever there is other whenever there is evidence of accelerated bone maturation, or whenever there is evidence of other adverse events or adverse events related to this growth hormone therapy. And when you have actually reached the genetic height percentile, or if there is a this genetic target height, then you can actually stop the therapy. So this is your second question.
50-year-old diabetic female on maintenance hemodialysis thrice per week for more than 2 years. BMI is 36 kg per meter square. Apart from insulin and antihypertensive, she is on calcium acetate 7 mg TDS and calcitriol 0.25 microgram. History of fall and fracture neck of femur left, followed by hemiarthroplasty 2 months back. DVT in left lower leg, warfarin started and presently on 2 mg OD, INR is 2.2, presented with development of painful elongated indurated lesion over thighs and lower abdomen more than 2 weeks. In the lab, CBC 9.1, count 17,800, platelets 2,05,000, fasting is 188 and postprandial blood sugar is 289. Urea is 154, creatinine is 9.89 milligram per deciliter. Calcium is 9.5, phosphorus is 5.5, and IPTG is 119 picogram per liter.
So this is the lesion.
Could be. Is there could be a hematoma formation?
The patient was on warfarin.
Warfarin is
parathyroid hormone. He was multiple calcium-containing drugs, and now has developed this. We describe this blackish lesion.
Sir, calcemic uremic arteriopathy. Warfarin.
Yes.
Calciphylaxis. What are the
Calcemic uremic arteriopathy.
So is it matching in this patient? An elderly person.
Yes, sir. She was taking calcium and vitamin D supplementation.
Yes.
That might have led to
warfarin.
Vascular calcification.
Was getting warfarin. Are these important precipitating factors?
Yes, sir. So, warfarin and precipitate.
So go to the next question. So what are the differential diagnoses? And what do we do for the diagnosis? How do you confirm?
Sir, biopsy can be done, or to see for the calcification, we can do imaging studies. We can do imaging studies like CT and angiography studies. We can do and see for the vascular calcification. X-rays we can do and see for the calcification.
So something is called a telescopic biopsy. Do you know what is that and how it is helpful in such situation?
I've heard of it, but I don't remember. Like,
Suppose you have done a biopsy. What do you get in the biopsy in a patient of calcified axis?
So there will be calcification in the vessel. There will be dermal inflammation. There will be clogging of the small vessel. They will be surrounded by inflammatory changes.
You can see the next slide.
What do you see?
So before that, Anuruddha can tell what is a telescopic biopsy.
So telescopic biopsy is basically when you are doing a biopsy for this calcified axis, you might need deeper tissues. So to prevent any co-mineralization and to get better deeper tissues, once a punch biopsy is done, usually other open biopsies are avoided when you are trying to biopsy a sample from this kind of a lesion. And you do a punch hole biopsy, and the second punch hole biopsy is done through the initial punch hole biopsy to get a further deeper tissue. So that's called a telescopic biopsy.
So what do you see in the biopsy? What is the stain and what do you see?
So that looks...
Arrow is given, we just mentioned about that.
It's above arrow looks like a granuloma formation.
What do we expect in such patient? You have told calcific arteriopathy. You have told.
So there will be vascular calcification and the calcium, metastatic calcium deposition, sir.
So do you see any metastatic deposition of calcium and other vascular changes? At the same time, there should be occlusion also. Otherwise, how can there be a necrosis? The two arrows are given showing two different findings.
So the lower arrow possibly suggests metastatic calcification.
Yes, this is a pink. This is a violet one. That is probably the calcium deposition is there. Another blue arrow. That is also a vessel.
Okay, sir.
But completely
occluded, sir.
Occluded. Okay. So, unless you want to say anything?
It is basically the basophilic stippling of presence of calcium in the intimal layer of the blood vessels. This is a completely thrombosed, fibrin thrombosed blood vessel. So another finding which can be found in the histopathology is basically calcific nodules in the formation of calcific nodules in the subcutaneous tissue. So this was the, as you were saying about imaging, these are the X-ray plates of the particular lesion. Can you describe what do you see?
So there is a trochanteric fracture and so it has been, an implant is there in the left hip bone, and so the bone is, the bone looks osteoporotic, sir.
Yes.
Left hand side there is a neck of femur fracture with an implant, and right hand side this bone is supposed to be, so then the cortical density is very
different.
Decreased.
That is also okay. It's near the neck, and the second, the lower end, that is the cortex is thinned out. But what is important you see in this other than bone?
We are looking at a soft something.
So there is a calcification of the vessels can be seen, sir. Walls of the vessels, they are calcified.
So are they important in terms of diagnosis and prognosis of the patient?
Yes, so since the patient is on calcium supplementation and vitamin D, so that could be one reason it has led to some extensive vascular calcification. So
if you do some calcium treatment in a patient who is not requiring it for bone, then it will be deposited to some elsewhere. It can be in the vessel, it can be in the soft tissue, it can be in the heart. So this is important. Okay, and then this is a good prognosis or a bad prognosis for future?
Bad prognosis. So they are more prone for cardiovascular diseases.
Okay. So what will you do for the patient? How do you treat a patient of calcified axis? Next.
So all the supplements has to be stopped. Calcium supplements and vitamin D supplements, they should be stopped. And
this is another question about the differential diagnosis. One question is the diagnosis. Second question is the differential diagnosis. See, it is one of the differential diagnoses. What do you see?
The medial calcification.
Calcification, or okay, there is some calcification is there, but mostly this is sclerosis. Okay. So this is a closed differential diagnosis. And here, what do you see?
So this is rugger jersey spine, sir. The
yes.
In the vertebra, upper and lower part is more.
Okay.
So it is more radiologically prominent, and there is the mid part is radiolucent. So
MBBS, you have heard this name of rugger jersey spine. Now you have to know some scoring system based on this finding, not only in the bone but something in front of bone.
So in front of bone, there is a aortic calcification. So the calcification can be seen, sir. Yes. Calcification of the artery. So clinical applications likely secondary to renal disease, secondary hyperparathyroidism, or renal osteodystrophy.
Okay. Next.
Scoring systems, sir, I don't know what's scoring system.
Okay. You should read. Go next slide.
So this basically showed there was calcification in the lateral diagram of this aortic calcification. The main clinical implication, it actually highlights underlying very increased cardiovascular morbidity. And the other scoring system which can be used are mainly Adrogau's and the Kupila scoring system. The Kupila scoring system actually looks at the presence of calcification in front of the lumbar vertebrae, and you score in terms of the calcification, whether it's involving the anterior or the posterior wall, and how much length of the vertebrae is involved. And Adrogau's scoring system is based on the absence of calcification rather than presence in arteries of hands and the iliac and the femoral vessels in each quadrant. Actually, when you divide it in the quadrant, and if you are not able to see any calcification, then you classify it. So again, these are mainly the risk factors of the calciphylaxis, mainly in patients who are on kidney replacement therapy, and the patients who have abnormal calcium phosphate homeostasis, especially hypo and hyperparathyroidism, and treatment with vitamin K inhibitors like warfarin, and in patients who are mainly female and diabetic patients have a very high risk of undergoing this uremic calciphylaxis. This highlights the pathophysiology of transformation of the muscles into osteochondrogenic VSMCs and the role of vitamin K inhibitors. And the differential diagnosis, as we were talking, in this kind of patients, very close differential would be warfarin-induced skin necrosis and the atherosclerotic vascular diseases, as well as dystrophic calcinosis cutis. Mainly in calcinosis cutis, the calcification is not involving the blood vessels, it's mainly in the subcutaneous tissue and the soft tissue, subcutaneous tissue. So the primary treatment is to basically to stop the calcification of blood vessels. You have to correct the underlying hypercalcemia, hyperthyroidism, and you have to stop vitamin D and calcium supplements. You have to stop warfarin. Dialysis frequency may have to be increased, and for decalcification of the blood vessel, the drug recommended and the drug which has been used is mainly sodium thiosulfate. The dose again is what I've highlighted, and the duration can be from 2 to 3 months up to 6 months after and vitamin K also can be used in an oral dose. And local wound care and pain control is very important because the lesion can be excruciatingly painful. The main mechanism is the chelation of calcium and formation of a soluble product known as calcium thiosulfate from the sodium thiosulfate. And again, this mainly, as we all know, it was mainly used as an antidote for acute cyanide poisoning initially, and now it has been it's undergoing off-label use for use in calciphylaxis, and multiple trials have come up. And the dose mainly for calciphylaxis is after a test dose of 12.5 grams weekly, 25 grams thrice weekly, and intralesional per session. And the other trials for use of drugs in calciphylaxis mainly is for this calci, in which sodium thiosulfate and other interventions are compared. And another trial was trial called Calcifix, which again is on mainly the inhibitors, the drug which is undergoing recruitment. And the compilation of and meta-analysis of the multiple trials actually showed that there was beneficial role of using sodium thiosulfate in terms of prevention of or reduction in the risk of death, as well as improvement in the skin lesion, as well as the time to event in this particular group of patients. So coming to your last question.
Somebody has asked about the name of the scoring regarding this aortic calcification and the Ragard spine. Just to
it's called the when you are using a lateral X-ray of the abdominal aorta, it's called Kupila scoring system. And when you are using this absence of calcification in the iliac and femoral vessels and in the vessels of your hand and forearm, it's called Atrogau's scoring system.
So we'll be posting these slides in the YouTube, so you can see that also. Okay, go to the next. This is the, I think this is the last question.
This is the last question.
Yes.
55-year-old female, known case of CKD, on dialysis thrice per week. Dialysis vintage is 2 years, complaining of back pain and lower limb pain, occasional pleuritis. In CBC, hemoglobin is 8.1, total count 4,500, platelets are 1,21,000, creatinine in 8.7, calcium is 8.1, and phosphorus is 7.2.
Okay. So
25 hydroxy vitamin D is 14.5 nanogram per ml. IPTH is 980 picogram per liter. Alkaline phosphate is 700 international unit per liter. First treatment of choice. So we'll have to. So since the phosphorus is on the higher side, first we'll have to take care of the phosphorus. Phosphorus has to be phosphorus has to be reduced, and then vitamin D, since the levels are insufficient, so we'll have to supplement vitamin D also. But in this case, since the phosphorus is on the higher side, we'll be little bit careful while starting vitamin D. But since it is so much insufficient, we will have to supplement vitamin D also. So first, control of increase.
What is the primary target? Primary target is to suppress this very high PTH.
Yes, sir.
So you start with the phosphate binder.
Yes, sir.
Okay.
First we'll start phosphate binders, and then we'll supplement vitamin D. Cholecalciferol specifically.
What will happen? If you start with this vitamin D or the calciferol before giving a phosphate binder, what is the problem?
It can lead to increased absorption, intestinal absorption of phosphorus, vitamin D, or can lead to. So that will further worsen the phosphorus level.
Okay. So first control the phosphorus, then you start. If the now vitamin D is lower side, so you start with vitamin D, and if it is okay, then you go for this is calciferol. Okay. So
yes,
last part you read. Yes, you read. You have given this phosphate binder and this vitamin D supplementation to such patient, and now this is the result.
Calcium is 8.79, phosphorus 6.1, hemoglobin 9.8, vitamin 25 hydroxy vitamin D is 29.5, and IPTH is 559. So the phosphorus is still on the out of the range. It is recommended to bring it below 5.5. So in such cases, sir, we can use so apart from phosphate binders, we can use cinacalcet.
Okay. So what is the group called? Calcium mimetics. So
yes, sir. Calcium mimetics can be started.
So before that, what do you see and how do you assess the response?
So the phosphorus has to be first. Anti-phosphate treatment should be initiated first, and then we can use calcium mimetics. And so we have to monitor the calcium levels while starting after starting calcium mimetic, we'll have to keep a monitor calcium and phosphorus level periodically.
You are worried about hypercalcemia.
It can cause hypocalcemia, sir.
Yes. Next slide.
You
see this image and give your comment.
Sir, NHE3, it is a new drug for newer phosphate binders. So the name.
Are they called phosphate binders or some they call a phosphate? It is written absorption inhibitors.
Yes, sir.
Okay.
I remembered the name, sir. Just a second.
This part of the teaching session I do whatever you don't write or cannot remember, just to give an hammer to that. Okay.
Sir,
yes, you know about the, you read the slide. This is you read the channel and may not name the drug, but their mechanism you can read it from this slide.
So it is basically sodium hydrogen exchange. It blocks that. It was initially used for so diarrhea, constipation. It was used for.
Yes.
Constipation. These drugs were initially used for constipation, and it was found to bind phosphate. So it was used, sir. Okay. In refractory hyperphosphatemia, sir, we use this. If the phosphate levels are persistently above 5.5, then we use this, sir.
Okay. Next slide.
the name of the drug which can be used in additionally when we are refractory hyperphosphatemia. Top of the phosphate binder is tenapanol.
Tenapanol, yes, sir. Tenapanol. Tenapanol can be used.
FDA approved. So this again, the patient was complaining of back pain and body ache. So this patient went at DEXA scan. So can you identify the scoring?
Usually T score is done to report the DEXA scan. So the T score is
yes. So how do you diagnose osteoporosis from this? Because we are discussing all these things because these are important for the patient. This contributes to the life of the patient. So what is the test and how do you see? Whatever the T score, how do you define osteoporosis in this patient?
So the test is dual X-ray absorptiometry DEXA scan, and T scoring is done.
Yes.
So less than minus 2.5 is osteoporosis, and 1 to 2.5 is there's decreased bone density. So if the T score is less than 2.5, that suggests osteoporosis. And here it appears that the T score is below that limit, sir.
It is nearing about between more than 3 to -3 to -4 in between.
Yes, sir. If it is
osteoporotic. Okay, next. What will you do for such patient? He had already.
There are anti-resorptive treatments and there are anabolic treatments also. In anti-resorptive treatments, we can use bisphosphonates. If the patient, again, the guidelines differ if the patient is a CKD, but in general, we can use bisphosphonates and we can use denosumab. And in anabolic agents, we can use PTH analogs, ethyl-calcitide, teriparatide. Teriparatide we can use.
So
and
osteoporosis in CKD on dialysis patient is important because so many drugs you cannot use. Some newer drugs you have to use with caution. So just to give a summary for that. Next.
The patient was continuing on thrice per week maintenance hemodialysis after a vintage of 5 years. Presented with acute pain in the hip. And she has a long-term history of generalized body pain. So this was the X-ray of the patient.
So there is a neck of femur fracture is there.
Yes. So severely osteoporotic patient for a long duration dialysis developed a fracture neck femur.
Yes, sir. In the reports are hemoglobin is 9.5, pounds 4,800, platelet 2 lakhs, albumin 3.7, urea 116, creatinine 9.3, 25 hydroxyvitamin D 28, calcium 9.1, phosphorus 5.1, and IPTH is 2,273. IPTH is quite high, sir, in this patient.
Okay. So what do you expect? Okay, go to
So
next.
secondary hyperparathyroidism.
Secondary is already there for so many times. So if it is more than 2000, then what do you think? It's a very high. It is not
Yes, sir.
responding in spite of your phosphate binders and vitamin D supplements and so
It
on.
could be tertiary hyperparathyroidism if it is persisting for quite long.
So does this imaging helps you in diagnosing a severe hyperparathyroidism? This will be shown in your exam
left,
as X-ray.
sir, in left hand side, I can so there is a regular jersey.
Yes, on the right hand side.
So is there? So right hand side, I cannot appreciate. Is there sclerosis?
You just go to the distal phalanx and see whether periosteum is attached with the bone or is it some radification underlying this periosteum.
Yes, sir, there is some changes. The periosteal
What is
issues.
it called? Okay.
Periosteal reaction.
Resorption. Subperiosteal resorption.
Subperiosteal resorption. Next, what will you do? More than 2000, there is a bony changes, there is already a fracture, spines are weak, and complaining of severe body pain.
Sir, if the patient is already on phosphorus binders and calcium mimetics, then we can plan for parathyroidectomy.
Even though you don't have any adenoma.
So we'll have to get a parathyroid system maybe scan. We can see. So we can do a system maybe scan to see for any formation of.
That is not widely available. So what else you can do? What is
ultrasonography?
What is this? Investigation, what do you see?
So USG.
Written thyroid. And
yes,
then,
thyroid axial, left thyroid long.
Yes, there is an arrow and showing some hypoechoic lesion. So there is an adenoma. You can see the parathyroid is enlarged and there is an adenoma in the gland. Okay, in the neck. This is a simple way to exclude, and this is the sophisticated way to do what you are telling if you have facilities.
System maybe scan.
Yes. What next?
Options in treatments are that has to be removed. Parathyroidectomy part can be done.
Okay. So what are the indications of parathyroidectomy?
So if it is not responding to medical treatment, if there is diffuse bone pain, pruritus, intense pruritus, recurrent bony fractures, and not responding to some medical treatment, we'll first try medical treatment. Then
see in the next slide, how do you manage such cases? Ideally, how do you manage? Okay. Great.
So, according to the management of, according to this presence of low GFR in the patients can be diagnosed with osteoporosis on the basis of their DEXA scan and T score. If the patient has doesn't have any kind of fracture, or the patient's T score is more than 2.5, you essentially have to look at the turnover of the bone. That bone turnover can be assessed by using the parameters like bone-specific alkaline phosphatase and the presence of parathyroid hormone levels. if the levels are low and the bone specific alkaline phosphatase is low, ideally which highlights the presence of low turnover disease. In these cases for osteoporosis, you have to select anabolic agents like teriparatide, which you were saying. And in presence of high turnover bone disease, where the parathyroid levels are more than the 9 times the upper limit, and also the bone specific alkaline phosphatase levels are high, the patient have to be treated with anti-resorptive agents like donezumab. So patients who have the level in between the range, for them ideally to identify bone biopsy is supposed to be done. But again, if that being rare, most of the time using the parameters like we go clinically and use the laboratory parameters to identify and then treat. And again, this is a summary of comprising of the mainly the phosphate binders. They can be calcium containing non-calcium phosphate binders, and also the newer generation iron containing calcium phosphate binders. And last and foremost, the mechanism of action of this tenapanor, which mainly by inhibiting the sodium hydrogen exchanger in the intestinal apical brush border cells, it actually increases the intracellular proton levels, which again modify the junctional changes, which inhibit the paracellular pathway of absorption of phosphate in the gut. So a Japanese study which came out in 2023, it showed that on addition of tenapanor, there was significant reduction in the mean phosphorus levels when compared to a placebo, although this particular arm had very high, comparatively higher incidence of diarrhea, because tenapanor usually is used, initially was used to treat constipation predominant IBS. Again, this chart comprises of mainly the calcium mimetics. Usually what we use is cinacalcet, the other IV form of ethyl calcicide, and evocalcet is also there. And overall, this chart gives you a basic highlight how and when we use agents, whenever the serum calcium levels are high or whenever the serum phosphate levels are high. Whenever there is lower level of phosphates and lower level of calcium, we usually have to increase vitamin D if there is hyperparathyroidism, and if there is presence of lower amount of parathyroid, that is it going towards low turnover kind of scenario, then the calcium mimetics and other stimulant agents are to be brought down. And mainly the signs and symptoms, the biochemical parameters when we consider for parathyroidectomy is whenever we have a persistently elevated serum parathyroid level, which is not responding to therapy by active vitamin D analogs as well as calcium mimetics, if there is less than 30% of reduction, if there is presence of uncontrolled hypercalcemia and high level of bone turnover markers, and if clinically the patient has significant complaints like pruritus, pain, and underlying calcemic uremic arteriopathy, or presence of recurrent fractures and large parathyroid gland dimensions, then these patients can be considered for parathyroidectomy. And the parathyroidectomy usually can be total or subtotal, depending on the type and the number of nodes getting involved.
So thank you, Aniruddha. But this session is mostly for the things we don't read or much, like calcified axis, growth hormone treatment, and this CKD, MBD. There are so many agents are available that how you should use rationally in your clinical practice, because all drugs are not for all patients. Newer and newer drugs are coming. You have to be very much aware of these indications and the contraindications of these drugs, and so that you can practice rationally in your future when you become a nephrologist. So with this, we end our today's session. We thank, I think, Dr. Narayan Prasad for being with us, because such a great teacher you don't get so many times. And also thanks to the whole our Regain Classroom program, especially Mr. Saurabh, who has handled this program singly without any technical help, and most interesting, without any technical glitch. That is important. Thank you very much for doing this slightly longer class. Over to you, Mr. Saurabh.
Yeah, thank you very much, sir. It is our pleasure to be associated with Ring and PG Classroom. Before we go for the closure of this particular class, I just would like to make two announcements. One, whether this particular class is going to be posted in the YouTube, the answer is yes. But you have to give me some time because this whole recording is there in my laptop. I'm going to post it in couple of days from today itself. That is number one. And number two is that with the forthcoming the second class that is going to commence in this particular month is going to be 29th of March instead of 22nd. So kindly make a note of it. So this is the second announcement. And the third one is my wish that 13th of March happens to be the World Kidney Day, and I would like to wish each one of you present in this particular call a happy World Kidney Day. And with this particular effort of conducting regularly this REGAN PG program, this is our endeavor to make advancement in the kidney health by increasing and enhancing the wisdom in each one of you. My heartfelt thank goes to Professor Dr. Narayan Prasad for spending invaluable time and then enriching us with his deep knowledge. I hope that Dr. Tanmay Rai would be deeply indebted for this particular class that he has got today, and obviously under the guidance of Dr. Pratik Das and Dr. Aniruddha Datta, I cannot thank but this is my heartfelt thanks to each one of you for making this particular class happen. Thank you, sir, very much, and looking forward to present you the second new class on 29th of March. Thank you very much, sir. Good night and take care. Thank you very much.